So this is Wahid Kazai. Today we are presenting EACTA Thoracic Webinar, Recent Advances in Lung Isolation Techniques. We will acquaint you with common methods which are used successfully in our practice in large thoracic centers. We will present. We will also update you on new developments in this area. By the end of the webinar, you'll be able to define indications and relative contraindications on using double lumen tubes or bronchial blockers. We will show you how to integrate video-assisted intubation and video-assisted lung isolation techniques in your practice. We will show you how to make appropriate decisions regarding lung isolation and one lung ventilation with anticipated or unanticipated difficult airway, and we'll discuss airway management in very special case of lung transplantation. As we're talking about airway management, we will not only have a theoretical discussion, we will provide you with practical advice on how you can integrate this in your daily practice. The next talk will be by Professor Laszlo Szegedi, and he's going to talk on video-assisted tracheal intubation lung isolation. I'm sorry, I mixed it up. Laszlo.
No problem, Wahid. Thank you for this introduction, and hello everybody. Hello again for those who joined us later. My task, let's say, it's rather either very difficult or very easy, because almost everything was already said. So I will try to synthesize what was said, and I will say I will complete maybe what was not said. That's it. Video-assisted tracheal intubation and lung isolation, as every one of us knows, hypoxemia during one lung ventilation, it was told before, it decreased dramatically. Let's say from 25% in 1973 to 8% in 1993, reported by Peter Slinger, and thereafter in 2004, 4%. And let me say, moreover, I would like to say that nowadays is even less than 1%. No one claims anymore about hypoxemic problems during one lung ventilation, or very rarely. And that because of, that's a multifactorial issue. I mean, there is a better anatomical and physiological knowledge. Of course, we know, every one of us knows anatomy, bronchial anatomy. We have better lung isolation material. We use routinely fiber optic bronchoscope. We have good anesthetic drugs, and we see the patients preoperatively. We can ventilate better the patients, and our surgeons are working better, of course, too. There are new surgical techniques that maybe facilitate let's say, not one lung ventilation, but our task somewhere. And of course, we moved from oldish material like this Carlen's tube. It was said before, it's almost 80 years old, very bulky, with this carinal hook, which was reusable. We moved to modern double lumen tubes like this one, disposable, right and left sided. And of course, nowadays we have the bronchial blockers, from the Univent to the Fuji, Cohen, and of course the EC blocker. But I ask you one question, and Wahid already asked it partially. If you are coming back on a Monday morning from holidays or after a long weekend, what do you do with this patient? You didn't see him before, and you have to do one lung ventilation. The surgeon is there, you're feeling the warm breathing of the surgeon in your neck, and he's asking you, I want one lung ventilation on a Monday morning. So we are living in a 2.0 era of the thoracic anesthesia, let's say, so we have modern devices, and we can do it nowadays, fortunately. But as you know, in a claim study of Kaplan more than 20 years ago, he showed that 30 to 40% of death causes was because of difficult intubation in general anesthesia, not just in thoracic anesthesia. And intubation is mostly done with this device. Everyone knows the laryngoscope. You know, the problem is with the laryngoscope that the laryngoscope you didn't evaluate since more than 100 years, since its discovery in 1907 by Chevalier Jackson. It remained the same, and you should align your airways to could introduce your tube, as it's shown here with the green arrow. So therefore, we have, fortunately nowadays, in the as I told you, in the era of the thoracic anesthesia 2.0, several supportive tools and adjuncts that can facilitate endobronchial intubation. And we're speaking about intubation, endobronchial intubation, should speak about extubation too, of course. So we have fiber optic bronchoscopes, more and more modern, videolaryngoscopes, fluoroscopy intubation, extubation adjuncts, airway catheters, and so on. It was already told. But with the videolaryngoscopes, it was shown that we have a better laryngeal view. And we don't need airway alignment to intubate with a double lumen tube. I would like to insist it with a double lumen tube, not with a single lumen tube. And it was already used in 1999. So imagine it's more than 20 years ago. Shulman and Connell used it using a Bullard laryngoscope. Moreover, videolaryngoscopy is for double lumen tube intubation is associated with better glottic visualization, but better glottic visualization doesn't mean necessarily better or easier tracheal intubation. Now, what's the difference between videolaryngoscopy for double lumen tube intubation versus direct laryngoscopy? There is a higher success rate at first attempt. Lower incidence of oral, mucosal, or dental injuries and postoperative sore throat and comparable intubation time. All this if it's done by experienced operators. Imagine someone who never used a videolaryngoscope, he cannot use it. So even if you are a good anesthesiologist who's never seen one videolaryngoscope, you cannot use it. Let me say, unfortunately, the use of videolaryngoscope can be associated with a higher incidence of malpositioned double lumen tube if you are placing it. And indeed, we have a large number of available videolaryngoscope on the market. Here is the CMAC from Storz, the AirTrack, everything, the glide scope everyone knows, and so on. But mainly we classify them in three main classes: with an angulated blade, with a guidance channel, a lateral side channel, or the video stylets. And the performances are likely to be different between all these devices and are superior to the direct laryngoscopy. Now, that's a question. No one of you, I suppose, knows this guy. Is John Allen Pacey. He used to be a vascular surgeon. I mean, he used to be because he's living from his royalties. He's the inventor of one of the most well-known videolaryngoscopes on the market, which is the glide scope. Everyone knows it. No one knows his inventor, and it was not an anesthesiologist. It was a surgeon. So as I told you, we have the Trackway, the King Vision, the Pentax scope, the yellow AirTrack, we have the CMAC, we have the McGrath, which is really a pocket-sized videolaryngoscope with a pocket-sized screen. Let me say, other brands like the CMAC or the GlideScope, they have two small screens, models with small screens to could use in remote locations. And another type of videolaryngoscope is the Bonfils intubation fiber optic bronchoscope. It was described to be used for introduction of a double lumen tube. However, it was described to use for a double lumen tube, but in this case report, the authors report that they had to amputate, let me say so, the double lumen tube because and to connect it with a 6.3 millimeter tracheal tube because otherwise the Bonfils intubation fibroscope was a little bit shorter than the length of the 37 French double lumen tube. So, but it can be done. It was no problem at all. Here is the glide scope. As you can see, you have to bend your double lumen tube because the glide scope has a tip which is going up at 60 degrees. So you have to bend it to have to could introduce it. So it's easier to bend it according to the curvature of the glide scope. The same thing when you are using the air track, and the same thing when you are using the King Vision. Here to show you with the glide scope again, you are bending the tube, but you have two kinds of bending it. Either with the non-concealed tracheal orifice outside. That means that the tube will be, maybe it will provoke a lesion at the vocal cords. If you're bending it with the tracheal orifice inside, it's maybe easier to pass through the vocal cords. Here is the same thing. You have to bend the tube for the CMAC laryngoscope too. Here is the yellow air track, or this air track was done for double lumen tubes. But here for the double lumen tube, you should remove the stylet inside the double lumen tube. You shouldn't bend it, otherwise it will not go through correctly. As Wahid told us, or I think that Wahid was it, there are a lot of airway exchange catheters, or either airway exchange catheters or airway or tube introducers on the market. I just want to say to you, there is the most commonly used, one of the most commonly used are this kind of tube introducers on the market. Here is the Frova from Cook Medical. And here Cook Medical 2 is the commonly used tube exchange catheter and the double lumen tube exchange catheter. They are different because the double lumen tube exchange catheter has a softer tip, and the tube exchange catheter, and moreover the tube is longer than the normal tube exchange catheter. That's one of the points. I will come back to it in a moment. Here you can use an airway exchange catheter to introduce your double lumen tube. And here is the introducer of Frova, Cook Frova introducer, which is normally used for a single lumen tube. I know that there are people who use it for double lumen tubes. You may use it, but it's on your own risk, because there are some case reports which describe that if you're using it with a double lumen tube, first you should try it to see if it fits into the through the bronchial lumen of a double lumen tube. But secondly, there are case reports described in the literature which are saying that, which are describing the broken tip while using it with a double lumen tube. But he told you about this tube exchange catheter. So there is the tube exchange catheter, the yellow one, and there is the green one. I don't have any picture with it, for double lumen tubes. You have for double lumen tubes 11 and 14 French for more than 4 millimeter or more than 5 millimeter internal diameter endotracheal tubes. Now, let me say, if you cannot remember the sizes, and even if you can remember the sizes, but you don't know the sizes, one of the best techniques that I could recommend to everyone is first to try to pass through the lumen of a double lumen tube outside the patient and see if it fits before you are getting into the patient and try to intubate or to change the tube and so on. Otherwise, you can get in trouble. Now I will come back to a survey done a couple of years ago by the EACTA Thoracic Subcom, and we asked thoracic anesthesiologists, mainly thoracic anesthesiologists, to answer some questions. What are their habitudes? And they answered us that all of them are using fiber optic bronchoscopes. And indeed, to position the double lumen tubes, or either the double lumen tubes or the bronchial blockers, they are using all of them fiber optic bronchoscope. And indeed, fiber optic bronchoscopy is something, I think it was a milestone in thoracic anesthesia and in difficult intubation. I mean, it's from 67 on the Japanese market. It was something excellent, but as I told you, it's thoracic anesthesia 2.0 nowadays, and